Good morning, everybody. I'm very happy to introduce our speakers from today. We've been talking about it for the past couple of staff meetings. We have with us today Dr. Kim Choma and Dr. Meg Kaplan from Columbia, and they're going to be presenting on the importance of pap smears and doing a trauma-informed pap for our women in HIV. So without further ado, I want to thank the previous training from HRSA.
And so I'm going to start first. What we're going to do today is talk about the pap smear process. So not all of you do pap smears here, so it's going to be very eye-wide opening for you today, especially when you see some of the graphic images that are in there. So welcome to Anatomy 101 of the cervix. We're going to describe sexual trauma and its effects. That is very important for us to understand for each one of these exams that we do, not just in HIV-infected women, but all women. And discuss modifications that we can make to pap exams that take into account sexual trauma. Okay. So let's talk about HIV and cervical cancer. In most circles, not all circles, but most circles now, cervical cancer is an AIDS-defining illness. If you have cervical cancer and AIDS, they go together. Unfortunately, back in the 80s and 90s, when we weren't recognizing this pattern, they discovered that, and now, though, with effective ART, that's not so much seen today. So if we get these patients in the system, get them screened and get them treated, they're going to do much better and do as well as the immunocompetent population. The incidence, okay, now here's one of those abbreviations you're going to scratch your head and say, I don't know what the hell you're talking about if you're not in clinical medicine. Cervical intraepithelial neoplasia, or what's known as CIN. It's high-grade disease that I'm specifically talking about. This is high-grade disease, CIN. Is 4 to 10 times higher in HIV-infected adolescents and women. And 25% of women with HIV are not screened for cervical cancer despite seeing a primary care provider. We don't know if this is a system failure, a problem on behalf of the primary care provider that's seeing her at point of entry to care and not pointing her to GYN services, or in fact just doing her on that day that she's admitted to services. That would be the ideal situation, is having a pap smear screening done that day. Now what you're seeing here, it's kind of hard to see on the screen here because of the lighting, but you can look at your handouts if you want a little bit more detail. Or maybe we can turn the lights down, that would be great. Ah, much better, okay. The cervix is a dynamic process where two cell types meet and change from one cell type to another. There's not very many places in the body that does it. It does it in the oropharynx as well and in the rectum. Never in any other place in the body do you see that. And this especially happens at vulnerable times in our lives when we're adolescents and puberty. Our hormones hit. The area where cervical cells and columnar cells and squamous cells meet are inside, deep inside when we're young little women. And then as we become exposed to hormones, they come outward onto the cervix. And that's what you're seeing here on this cervix. You see a line here, you can't see it up here, but this beefy red cells right here are the columnar cells. This nice flat cell area is the squamous or epithelial cells. This transformation zone where they transfer from the squamous and columnar cells is known as the transformation zone, or the squamo-columnar junction. You'll hear both of those turn back and forth. That's a very important area if you're doing pap smears to be sampling, because that's where the HPV harbors itself and causes disease. Now, all these cervixes, believe it or not, that I have on here are normal. So contrast the one on the bottom left to the one on the bottom right, where you could see, usually that's what you see when you do an exam, just the tiny little os of the cervix, and you can just barely see in here the little red columnar cells here. Imagine if you're just using a broom to do your pap smear. On that one, you'll get your cells that you need, but if you do a broom here and here's the os, what are you missing? The transformation zone, and you're going to get an inadequate sample. So this is why I put this slide up here for you to see. The next one, the slide 2 on the left, you can see where the columnar area should be. It's got patchy white lookiness to it. That's because it's turning into squamous cells. Then the slide over to the far right, where it has a smiley face to it, that's probably somebody who's had a vaginal delivery, and that's why it doesn't have that hole there. But you could see the difference between the columnar cells and the squamous cells, and you have to be cognizant of that when you do your exams to make sure you're sampling the area adequately. So what I'm going to talk to you about now is the natural history of HPV. It's so interesting that I can mix those up too easily. HPV infection in the non-infected HIV woman. We don't know what the natural history of HPV infection is in HIV infected women. But within 1 year, they'll get an initial HPV infection. And it can persist and turn into what's called SIN1. Now remember I said SIN1 before, or I said SIN before. We have SIN1, we have SIN2, and we have SIN3. SIN1 is an HPV infection. SIN2 and SIN3 are precancerous lesions. Okay, those we get upset about seeing. So she has a SIN1 lesion. It can persist, and we can eventually lead on to SIN2, SIN3, or cervical cancer, or she can clear it, especially if she's younger. This is why we no longer pap smear adolescent women anymore, regardless of sexual debut or how many partners they've had, because they have a very low incidence of cervical cancer. So why should we be doing a test screens for cervical cancer in a population that doesn't? It's very common for it to clear in 2 to 3 years. Now, you don't go from SIN1 to SIN2, SIN3. It's not a linear relationship. You can go to SIN1 and then to SIN3. You can go from a normal cervix to a SIN3 cervix. There's no rhyme or reason to this with HPV. There's no logic, is what I want to say. But the one thing is it takes 5 years to progress to a SIN2, SIN3 lesion, and it could take up to decades to turn to cervical cancer. And that's what we have on our side. If we screen our patients appropriately and on the right intervals, we can catch it, we can treat it. It's a very treatable cancer. Thank goodness that's why this country has a low rate of cervical cancer deaths, because we are screening most of our population. Second and third world countries, they have a much higher incidence of cervical cancer. It's number 2 or number 1 killer of women. And you need to be cognizant of that in your population that you serve if you have a large immigrant population, because they may come to you and you're screening them for the very first time. Is there any way we can get a little air in here? They're all waving at themselves.
We can open the door.
Open the door. Okay, just keep it quiet. I don't want you to pass out by the time I'm talking. I see the fans going. So what I put up on here is, if you have a question, just speak it loud for me.
In reference to the slide before, you had how effective is the HPV vaccine?
HPV vaccine is very effective. So we want, and I'm going to bring the vaccine up later, we want HIV-infected women and non-HIV-infected women to get vaccinated in adolescence, because that's when their immune system gets the biggest bang for the buck out of that vaccine, not waiting till they're 14, 15 and in danger of having sex by then, and you miss the opportunity to get it to them when they're sexually naive. So yes. And that's why we're trying to get the population immunized so we can have what's called herd immunity. Do you know what herd immunity is? Herd immunity is to be vaccinated enough of the population. For those that don't get vaccinated, they get protection as well. But we haven't reached herd immunity numbers yet in this country, because we have a lot of backlash against the vaccine, thinking it's going to cause sexual activity when it doesn't. This is a cancer-preventing vaccine. All right, so 3 things I have here on this slide. On the top row going across, so I have rows and I have columns. On the top row is pap smear cytology. Cytology is the study of cells. So that's what they're looking at when you send them that pap smear. The second one are what we call couple photographs there. And they take biopsies of the cervix, and that's called histology. Okay, so it's different from cytology. And then I put the natural history where you can see it going back and forth. So in column 1 is a normal cervix with a normal pap smear. I'm going to use this chalkboard eraser. These are the squamous cells up here with the tiny little dots here. This is just artifact or infection. But look at the tiny little nucleus that's there. A lot of squamous cellular material there, very little nuclear material, and a normal looking cervix. Move on to the second column, we have an HPV infection. The nucleus has begun to enlarge or duplicate itself. And if you look here on the cervix, right here is this light white lesion right here. This is a SIN1 infection or an HPV infection. This infection can persist or it can regress in 2 to 3 years without any treatment, especially in your young, competent patients. Now, column number 3 is a high-grade lesion, SIN3. And there, look at the nucleus. What can you tell me about the nucleus that you see there? It's huge. It's taking up almost all the material that's in there. And our lesion that's causing that is right here. It's dense, it's thick, it's white, and it's sitting right where? At that transformation zone. Each lesion happens to sit at the transformation zone. All right, so we see a pattern here. The last one is cervical cancer. You have many cells with dyskaryotic features to the nucleus, different sizes, shapes, enlargement, broken cells. And if you look at the cervix, it's lost its architecture. You can't even make out where the os is there. So that's the thing that we don't see very often in this country, thank God, and hopefully you'll never see it either. So HIV-infected women have an increased risk of high-grade lesions and cervical cancer with advanced immunodeficiency. See, I think a lot of you know that already, but if you didn't, I'm telling you. But not with women who have preserved CD4 cell counts. But they also have a high rate of anal dysplasia, and that doesn't have to be with receptive rectal sex. They do not have to have rectal sex in order to have anal dysplasia. They can have vulvar lesions that can also spread down to the rectum. So this population, many experts recommend that we do screenings for anal dysplasia in this population. Is that happening here? Is there an anal dysplasia clinic?
We've had providers trained in the past in HRA.
Oh, an HRA, okay.
We're getting 2 of our providers trained this summer for HRA.
I'm getting trained too. So effective ART with immune reconstitution. So patient was immunocompromised, you reconstitute them with ART. This has not been shown to prevent the progression of sin. So if you've got a patient who's got a high-grade lesion and they've not been very good with taking their medications, they're immunocompromised, you try to redo them and get them rebooted on their ART, it's not going to help with that lesion. They're going to need treatment. So what is the presentations of early and late SIN and cervical cancer? Well, SIN 1, SIN 2, and SIN 3 can all have no symptoms whatsoever. Screening must be done to pick them up. Very rare that a SIN 3 lesion causes any problems unless it's very dense and ulcerated. But the classic symptom of cervical cancer is intermittent, painless bleeding between the menses. Late signs and symptoms are flank and leg pain, dysuria, hematuria, rectal bleeding, and obstipation. Now, obstipation is severe constipation, and that's because the mass is just pressing down on the rectum and not letting them go to the bathroom. So that is a late sign, and hopefully you never see that either. So we're going to shift gears a little bit and talk about clinical care practices, what we should be doing for our patients during this exam that we're going to be doing for them. So objective information that you want to get at your history taking. Some of this belongs on your lab requisition, and I'll point that out to you to make sure you're putting it on your lab requisition, because who's filling out your lab requisitions? Are you the clinician? No, it's usually your tech. So you want to go back and make sure it is the clinician? Wow, in my institution that I've been working with, it's always the med tech. So good, now it's all your fault if you get it wrong. All right, so genital warts, this is for your own history. Previous or current HPV infection. So every visit you want to revisit, because if they've missed a visit, did they have a visit somewhere else and something happened? You want to know about that. Prior abnormal pap results, cervical and or anal, those go on your pap smear results. All right? You want to flag and give as much information to your pathologist as you possibly can, because I don't know with your pathology department if they do automated cytology reading or if they do all manual with cytotechnologists. But if it goes out to LabCorp, for sakes, and they have an automated technology there. And then every now and then one's picked out of the bunch and given to a pathologist to read. You want to flag this, that this is immediately given to a pathologist. So by giving them information about prior abnormalities and prior treatments, we'll do that for you. Okay? Age of sexual debut and sexual partner history. What's their gender identity? We're going to talk more about that. Cigarette smoking. That's a big black flag, I like to call it. Not the red flag, but the black flag, because I know it does black to the lungs, so that's why I call it my black flag. But HPV persists much longer in your tobacco users, and it's hard for them to get rid of it. So you want to get them to stop smoking. If they're smoking and they're smoking a pack or more a day and they've got a long pack history, I might be more aggressive in my follow-up with them. Instead of annual PAPs or every 3-year PAPs, I'll drop them down to annual PAPs. You'll see in the algorithm later. I might even put them at 6 months if they're not immunocompromised and they're smoking as well. So that's clinical judgment coming into account. Pregnancy, that goes on your lab slip. Hormonal contraceptive use and also IUD use, whether it's contraceptive hormonal IUD or the Paragard IUD. Both of those should be on your pap smear lab requisitions because the pathologist needs to know that. HPV vaccination history, somebody asked about that there. So if they only got 1 shot and they're under 26, they can do catch-up at any time. You don't have to wait, you know, X amount of time. As long as it's been 6 months and they missed it, go ahead and give them their 2nd shot. What about sexual trauma history? I didn't ask that, so I'm going to let Meg jump in here and talk to you about that a little bit.
Okay, so how many people ask about sexual trauma history? Okay, so there are very good reasons why professionals don't talk about sex with their patients. One is it's very embarrassing and it's a taboo in our society. So most clinicians don't ask about it, right? There's a limited frame of reference. So if you're talking about sex in general with patients, they may ask you a question that you don't know how to answer. So if it's about something about the cervix, that's something you can look up. But if someone says, okay, do you think it's okay for me to have anal intercourse? How do you answer that? So we all have a limited frame of reference. We all have our own values and ideas of what it's okay. And so this, when we start to ask about sexual histories, it comes into our own histories as well. It's hard not to. And it's very hard to be objective, but one of the most important things is to try to be objective with patients. So the rule is if you ask all clients and someone says to you, why are you asking me this? You say, well, sexuality is an important part of everyone's life, and this is part of any exam for all patients, right? So one is ask all clients. Ask at the initial assessment as part of the psychohistory and psychosocial history, and I would ask it when you're asking other sexual questions in terms of trauma. And put it in context. So we're going to talk about how to bring that up in terms of trauma, because it's hard to just say to somebody, have you ever had sexual trauma? And we'll talk about, there's a lot of different kinds of trauma, but we're talking about sexual trauma, which may impact on somebody going for an exam. And one of the things I just wanted to use as an example of this to bolster it is that in Tuesday's New York Times, Science Times, there was a study about doctors don't ask, so patients don't tell. And they had a whole bunch of studies. So one, for example, was that 90% of transgender patients said they would like their doctor or their healthcare provider to ask them about their gender identity or about being transgender. And there's in the study, a lot of different studies about a lot of different sexual acts. But patients do want you to ask. Just healthcare providers are embarrassed by it and they think that patients don't want that. So we could get you that article if you're interested in it. Okay, so how to ask about trauma, how to even bring it up. So basically you want to funnel rather than going to something, if someone's been raped, it's very difficult to just start with that. So you want to funnel from general questions, and it's really up to you about asking those general questions. So you could ask, tell me a bit about your childhood memories, your best and worst memories, how is discipline handled, because that's going into physical abuse. You could ask, do you have any concerns about your sexuality, right? Or is there anything interfering with your sexuality? And a lot of patients will make jokes about that, and they'll say, I don't have any sexuality, or it sucks, or all kinds of things. But basically, this is a lead-in to asking about trauma. So then you would ask, have you had any sexual trauma in your past? And then you would ask what? Have you ever been, was it in your childhood? Was it in adulthood? Have anyone forced sex on you? Because that's what really, we're looking at sexual trauma for people that are just going to clench up during an exam or be really tense, and you're not going to know why. So it's really important to get that in the beginning. So Then a lot of clinicians say, okay, so let's say someone says, yes, I was raped, 2 months ago, or I was raped 5 years ago. How are you supposed to respond? You're not a trauma psychologist as I am. So the first thing is you tell them that I'm really glad that you told me that. That must have been very hard to tell. So you affirm them. You ask whether they're having any current difficulty. So if someone says I'm having nightmares from it, or I can't have sex because I get flashbacks, you want to know that. And then you offer support. You just say, I'm really sorry about that. I'll try to help you about that. Okay, so let's talk a little bit about trauma with people living with HIV, which is a little bit different. It's very high lifetime trauma exposure, and post-traumatic stress disorder is high among adults living with AIDS. Now, the difference between having had a trauma and post-traumatic stress disorder is people have different kinds of resilience and react very differently to all kinds of life experiences. So some people can have had a trauma such as rape and not be experiencing any symptoms from it. If people continue to have symptoms, then they would develop post-traumatic stress disorder and need treatment for that if they haven't gotten treatment for that. So 62% of HIV positive adults have had traumatic experiences. That's a huge number. Compared to, at the bottom, 8.7 of the general population, which is also high, but it's much higher with HIV positive adults. Okay, so what is the traditional definition? Is the person has experienced usually an event that had threatened death, injury, or threat to physical integrity. Now, a lot of people have had traumatic events that are not that, but they have the same response. So let's say someone exposes themselves, an exhibitionist exposes their penis to somebody. That person may have a huge trauma from that because they may be fearful that that person is going to follow them and rape them. So they may, and it's very variable. So it's not necessarily a hands-on experience. But the response involves intense fear, helplessness, or horror. And one of those things is that the person was out of control, so it's uncontrollable. And the reason we're talking to you about that today is that when someone goes for a gynecological exam that has had trauma and it's not been treated, you want to give them as much control as possible, because this was an out-of-control experience that they couldn't control and unpredictable, right? And it challenges self-concepts and really can affect someone's life. Now, the other thing, just before I go into this, is that it's important to know sort of when you're asking questions where you do know your own history. But if 8% of the general population has their own trauma history, then a lot of clinicians also have their own trauma history. And for them, it's more difficult to ask. So just also, it's important to be aware of your own feelings and what's going on with yourself. Okay, so there's disasters that are general trauma, car accidents, sudden deaths, or any deaths of loved ones. Certainly things for combat cause post-traumatic stress disorder. So someone could be coming in with any of these and still have a reaction to any kind of stress. But we're mainly talking about sexual abuse here. Okay? So these are just diagnostic categories of DSM, the Diagnostic and Statistical Manual of Post-Traumatic Stress Disorder. So someone that has had a trauma might have intrusion systems. So when they're having sex, for instance, they might be in a sexual relationship and having sex, but they might be having flashbacks, or they might sort of leave the room emotionally and really not be there at all. So these are symptoms that people have. And because of that, they may avoid exams, they may avoid sexual relationships. They may have negative cognitions in mood, that affect their mood, or cognitions of what they're telling themselves about, that no, I never want to be touched. It'll always be painful if I am touched. And just completely avoid anything that might resemble that. And arousal and reactivity is just being highly emotional and stressed at the thought of anybody touching them.
All right. So
Okay, we're going back and forth
back
because
and
we're trying to
forth
put
and-
this in.
We're going to jump in sometimes together with each other.
Any
So
questions about what I talked about?
just to keep you awake. So I'm focusing more on the cytology. So I talked to you before about the transformation zone and where to sample there visually. I want to talk to you about the tools of the trade that we use. So how many people here are doing pap smears? Okay. And liquid-based? Okay. So I'm going to just talk a little bit briefly about conventional cytology, and I'll move on to liquid-based. Believe it or not, they're still using conventional cytology, which is the spatula against the slide. They use it in clinics. They still use it in correctional facilities, and still using it in some hospitals, believe it or not, because there's some data out there that shows that the effectiveness of finding a SIN2, SIN3 lesion is comparable to that to liquid-based technology. What liquid-based technology has over conventional pap smears or the good old slide is that it can do a lot of co-testing. It can do your HPV, your gonorrhea, your chlamydia, your trick. Can't do that off a dry slide on a pap smear. So, but your three tools that you use are your brush, your cyto brush, and your spatula. Those are to be used together. And then you have your cyto broom. Now, I like the cyto broom better than the combination of spatula and cyto brush, but the problem is when you use a small speculum, it only opens so far, and the broom just barely makes it in there. I like the broom because it's softer and more gentle against the cervix and doesn't cause a lot of bleeding, but you turn it 5 times in one direction. Take it, you can go to liquid-based, put it in the liquid-based cytology specimen and push it down 10 times to release the material from it. You want to push that broom really hard. So are you guys getting your own? Do you have a med tech with you who's getting the specimen, or you're doing your own specimen? All right, so push it down 10 times, swirl it around really good, tap it against the side, and then throw it out, because the object is to not throw out all your cells into the garbage. You want it in the vial. If you use the spatula and cyto brush, the spatula goes up against the cervix, and you turn it once, one turn 360 degrees. And a lot of times it bounces off the cervix. You have to be careful with it. So slowly you do it so it won't bounce. And then you take your cyto brush and put it in there. And this is where a lot of people make mistakes. They put it in and they turn it 360 degrees again and again when it's only required by 1/4 to 1/2 turn only. You can cause a lot of bleeding and disrupt the cellular material when you do that, and you're not going to get a good specimen. So only 1/4 to 1/2 turn is needed for that brush, okay? Any questions on that? I know you're all not doing that, so we won't spend a lot of time on that. So now we're going to talk about the exam, and Meg and I are going to go back and forth with this, but this should not be your first step. I hope that when you're seeing patients at entry to care, you don't walk in the room and she looks like this, okay? You want to discuss the procedure with her first clothed, like on my next slide. So, and hopefully, even if she's in a patient gown, if she's comfortable, but clothed, she can see you eye to eye, and you're getting your history from her that way. But what about her trauma history? What modifications can I make for her during her exam? Well, we're going to talk about that in a few slides, okay, in different steps of the exam. So I'm going to let Meg jump in here, because this is important.
You know, trauma was also related to poorer health outcome. Post-traumatic stress disorder is associated with more health compromising and risky behavior. So that's why it's very relevant to know that to a trauma history. Many people that have a history of trauma have more pain and somatic complaints. So physical complaints that are not, where you're not going to find a physical problem, right? More, for instance, headaches due to stress, okay? And PTSD might also impact immune functioning. There's not a lot of studies on it, but it very well might. And treatable fatigue, treatment fatigue may be more pervasive among people with PTSD. So they're more reluctant to go for more exams or follow-ups or even their first exam. Okay, so sometimes even a diagnosis such as HIV can be a traumatic event for somebody, so it's important to realize that too. So diagnosis alone could cause trauma for people, and then they may want to avoid it or not even be in denial and not even deal with it at all. So they may not return to where they were diagnosed, never come back again from when they were first diagnosed, miss or cancel or just not show up for medical appointments. I don't know if you find that, but that's common. Unwillingness to adhere to medical regimen, and refusal to disclose one's status to significant others. So they also might be isolating themselves.
What's your recall procedure here for patients coming in for appointments or missed appointments? Do you have a protocol?
Yes.
Yeah?
We reschedule, call them, let them know you missed it, reschedule for this day, and then we just see if that day is okay for them. If not, they'll let us know what's more better, what's more convenient for them, and we just keep until we get it.
Okay.
So it's just important to be aware if you know someone has a trauma history, and this is another reason why it's important to know, because then you could say to them, this might be really difficult. We understand this may be difficult for you. We're really going to take a lot of time and be very sensitive to you because of your history. So you need to know that first. Okay, so what you can do when someone has disclosed, when you know that they have a trauma history, is be non-judgmental. A lot of people that have been raped blame themselves, and it's very common to think it was all my fault, so there's a huge amount of shame. So it's really important to be non-judgmental and very objective. Avoid over-identifying with the person too much in terms of, that's why we mean be objective, because even if you have your own history of trauma, it's important to sort of be objective with that person and not try to save them. So a lot of clinicians, I mean, we're clinicians and we want to help people and we want to save them, but that's really not what you're there for at that time. And that you may need to refer someone elsewhere if they need treatment for that. Be aware of someone being desensitized, just not, sort of like leaving the room, or being estranged, not wanting to deal with it at all. You don't need a similar experience to help somebody that's had trauma. And in terms of someone getting angry or violent reactions, I mean, I treat trauma all the time, and I've done this for 30 years, and I can only think of maybe 1 or 2 people that have gotten angry. So if someone gets angry, it would be very unusual, but I would just say to them, I'm really sorry that this has been brought up for you, but it's important because of, and tell them why. We need to know this so we can be sensitive to your past. Okay, so again, we're re-emphasizing this with patients with post-traumatic stress disorder or past trauma may really not want to go for exams because they find it very intrusive, and again, a gynecological exam re-traumatizing to them. Right, so it's important, again, to be really sensitive to that and supportive.
So what the goal is that we're going to teach you today is to give the patient control back. Okay, and you can see that as we go step by step through the exam, giving them back some control through the little things that we do. And Megan and I will talk about that.
Right, so we want to reduce symptoms that interfere with treatment, such as anxiety. If someone tells you they're really anxious, then you need to talk to them about how to what would reduce their anxiety, and we'll give you some examples about that. Talking to them about what they fear and can't avoid, for instance, for an exam. So a lot of patients fear that their gynecologic exam is going to be painful, and they have distorted cognitions or ideas about that, that I know this will hurt. So really talk to them about if they're saying that, what might hurt, what might be uncomfortable, and the more you could tell them what they're doing, this is about their daily lives, but the more that you could tell them about what you're doing, the easier it is going to be for the person. Okay, and that will help their coping ability. Increasing social support and family connections, because a lot of people that are HIV positive don't tell their people that they're involved with and their family, so encouraging them to tell people that will support them, and again, trying to increase their sense of control and safety where you can and where they can.
All right, my turn. So there's a lot of help out there for those of you who take care of HIV-infected women, a lot of resources out there. The manual that I've been using and another manual from ACOG and the CDC has lots of information for you, but they have specific guidelines of the care for a woman infected with HIV. And the reason why I put this up there is because one part of the exam is in debate right now for the immunocompetent woman, the pelvic exam. The pelvic exam is where the healthcare provider does an exam with 2 hands. That's why it's called a bimanual exam, to feel the uterus, the ovaries, and the adnexa, to feel for PID or masses or lesions. But the United States Preventative Service Task Force has not come out and said that this is a necessary part of the exam, as well as the American Academy of Family Physicians. ACOG, the American College of Obstetricians and Gynecologists, has still endorses it, but acknowledges there's no evidence to show that there's any benefit for or against a bimanual or pelvic exam. So I wanted to preface this slide with that, because you're going to see that on this slide. For HIV-infected women, they're still recommending that part of the exam. So you want to examine the external genital and perianal region. And when I mean examine, it's a stem to stern exam. It's not a look, okay, let me go put the speculum in and do the cervix. I've seen a lot of healthcare providers do that in training. You need to touch, because these women can have a lot of lesions that are inside labial folds or inside the buttocks against the rectal area. So I take my hands and I separate the folds as I go down, all the way down to the buttocks exposed to the anus, so I can see everything there, a stem to stern exam. You're not doing this woman any benefit if you don't start your exam that way. Change your gloves and then proceed to the pelvic exam, and to the pap smear exam, and then your pelvic exam. But you definitely want to look for warts, any kind of things that, like flat lesions on the vulva, on the labia, on the buttocks, and on the cervix. And if you do that simple exam of just looking and then going in, you're going to miss a lot of disease in these women. They have much more problems going on than just cervical cancer. They have vulvar cancer, they have vaginal cancer, they have rectal cancer. And so it would behoove us to make sure we inspect all those areas. Now, this is the fun part of the exam. Not. Only women laughed at that. Why? But a woman should be positioned properly in order to get the exam more comfortable for her. We're going to talk about how to get a woman comfortable for her. So let's hit the tab button. So given what she told me about her trauma history, what modifications can we make? Well, one, we don't want the head of the bed down flat all the way. Try to raise the head of bed up where you know that you're still going to see that cervix, but yet give her some comfortable visualization of what's going on in the room around her, all right? That's a control aspect for her. She can see what's going on, okay? Tell her why she has to come all the way down to the end. Because if the buttocks are not hanging off the edge of the table, the speculum will hit the table instead of going underneath the table lip, and will hurt the patient and will obstruct your view of the cervix. She needs to be all the way down. So I put my hands where she needs to be, and I tell her to keep coming until she touched my hands. Another thing, a patient says, I can't stand this. I don't want this done. I don't like this. And I say to her, well, I don't like it either. And I haven't had a patient yet say to me, bring it on. So you're in good company. Privacy. Would she be more comfortable with someone in addition to me in the room? By AMA standards, she's entitled to a chaperone in the room, and it doesn't have to be a med tech, but a chaperone. But to give her more control if she's had trauma, ask her if she has a family member with her. That family member may be able to calm her down more and make the exam easier for the both of you.
And you know, even if she doesn't want that, you're giving her more control. The more options you give someone with trauma, the more they feel in control of the situation, and that really lessens anxiety.
So we talked about the buttocks, but good lighting, and this is something I didn't even think of, and I thought I was doing it all for my patients, but does bright lighting remind her of a past rape exam? Because usually, where does the rape exams take place? Emergency room. What kind of lights do they use? Big, bright lights, okay? We use tiny little spotlights that don't give us enough visualization as it is, but that may trigger a response from her. You can have your tech use a flashlight if she doesn't mind the tech being behind the curtain with you, so to speak. Or I have a headlamp that I keep in the drawer of the exam room, where it's a simple camping tool with the flashlight that's here. You've probably seen that there. gives me great lighting and won't be affecting the patients with brightness at all.
Or just being sensitive, if you can change the lighting, I mean, sometimes there's a situation where there is, just telling the patient, I realize this lighting is very harsh, there's nothing I can do about it. You know, or even saying, would you rather close your eyes, or whatever will make you more comfortable.
All right, how much clothing can she keep on? Well, it depends on the exam that we're going to be doing. If it's an annual exam, she takes everything off but her socks, and we give her a patient gown. And hopefully it's a patient cloth gown, especially in this case, a little bit more clothing on her instead of a paper gown that can tear easily and traumatize the patient further, that they're being exposed, is preferable for this patient. If it's a PAP-only test and pelvic exam, then she can keep her top on. It's a waist-down exam. And I always tell them keep their socks on because the floor is cold. All right? More comfort, more choices to the patient. Now, have a mirror nearby. Hopefully you guys always have a mirror in your drawer, because the mirror can be twofold. One, it allows the patient to see if she wants to see, because she wants to be in control and make sure nothing's happening to her. But it's also for your benefit. If you see a lesion there that you've never seen before and you know this patient, you can say, look, I'm going to show you this lesion. Have you seen this lesion before? And if not, we're going to do something about it, or we're going to monitor it. You're going to come back and see me in 6 months. Anything suspicious, though, in the HIV population, I would say refer it out, though. Don't wait on it. Anything to add to that?
No.
No? So these are some of the references for you to look at with where I got some of my information from. I'm not done yet. We're almost there, though. Okay? But you have different nomenclature when it comes to the PAP testing world. You have PAP test nomenclature, which is known as the Bethesda system. It's been around since 2001, and it hasn't changed. We've had a lot of guideline changes, but the Bethesda system hasn't really changed, except for some other terminology. But the terminology for what we do when we send a patient who has an abnormal pap smear out to colposcopy, and the biopsy has changed. And so if you want to be familiar with that, go ahead and look it up with one of these resources here. Now, there's guidelines on how often you should be papping a HIV-infected woman. And for the first year, you begin within the first year, whether they're an adolescent or not, at first sexual activity, or we call it sexual debut. So women or adolescents, and they just become sexually active in the past year, get their first pap smear. Now, contrast that with the immunocompetent population. Adolescents do not get screened until they're 21, regardless of partners, regardless of how old they were when they had their sexual debut. Because we know, as we saw in that earlier slide, 4 to 10 times more women with HIV get dysplasia and abnormal readings than the general population does. Okay? And that transformation zone is getting hit with the HPV virus, and it's a very dynamic area. And think about it, how big it was in that adolescent picture that I showed you before, and they're HIV infected and they're having sex and get exposed to other infections, what insults can happen. Now, screening should continue throughout a woman's lifetime, e.g. don't stop at the age of 65. The current guidelines right now recommend stopping at age 65 for the immunocompetent woman who's been screened adequately, but these women are continuing to be screened until they don't come to the clinic anymore. We do want and recommend all HIV-infected women, even those who insist they're mutually monogamous, be screened for STDs annually. Sometimes you can pick up something that wasn't there before. So gonorrhea, chlamydia, trich, and BV, these all increase the risk of HIV shedding and transmission to other partners. So as we know in even the regular world, we don't know who slept with who, slept with who, slept with who, so we're just going to be passing it along. The big thing is we don't do tests of cures anymore. We're not following them up at 1 month for a test of cure. The CDC says stop that technique. We only do that in rare cases like pregnancy or child abuse, and we're using cultures with those patients. In this case, we're using what's called NAT testing, nucleic acid amplification tests. We're not to be using cultures anymore. These are more sensitive and more specific and give us a better result of finding the infection for our patient. But we're to use that NAT testing instead of 1 month later, 3 months later, because 17% or more of patients are reinfected at that point. What happens is they get their treatment, they're not infected at 1 month, but then they go back to their behavior, their partner wasn't treated, they get a new partner, and they're reinfected again. So the CDC now recommends retesting for infection at 3 months. So this is an algorithm I gave you for you of what to do for how often you should be doing your Pap exams in your HIV-infected woman. So entry into sexual activity, I like to say. Pap exam they get. If it's normal, you're going to repeat it in 12 months. If that one is normal, they get it annually for 3 years. So that's 5 Pap smears they're going to get annually. And then they could switch to every 3 years once you know they've had normal Pap smear readings for those 5 years. Click, please. However, at the age of 30, you could add co-testing to your regimen. Co-testing is testing automatically for HPV virus, and you can do that every 3 years in those women. We do not test automatically for HPV disease. It's very prevalent in the adolescent population, but when you do your test, you can do a Pap with reflex, so that if they come back with an abnormality of ascus, you can know it's HPV positive or not, how to triage them. And some of you are like, that's just going in one ear and out the other, so sorry about that. So just a couple abnormalities here. How we treat them? Well, some abnormalities we treat as the same as the immunocompetent population, and some we don't. Most of them we don't. The one that we treat the same is if they get a negative Pap, but they get a positive HPV. Well, you can use the guidelines to guide you to see what you can do next. We're treated the same that way. And in case you didn't know that, there's an app for that. ASCCP makes an app. It's a great cost of $9.99, but it's worth the investment in it because it gives you the cytology screening guidelines and the histology management follow-up. So women with cytology results or Pap smear results of low-grade squamous intraepithelial lesions should be referred to colposcopy. Okay? I'm sorry. I couldn't help myself. Women 21 and older with atypical squamous cells, referral to colposcopy is recommended if that reflex test is positive. So, and if reflex HPV testing is not available, then repeat the Pap in 6 to 12 months. And if you get another ascus, send them on to colposcopy. So do you have reflex testing available to you here?
The lab says they do it, but so in theory we do.
Yeah.
Yeah.
It should be reflexed, yeah, if you can. It just saves an extra step. But the reason why I'm saying that is because, remember, there's such a loss to follow-up for these patients. So you don't want to have to drag them back in to do an HPV test if you have that separately, or drag them back in 6 months. If you know it's ascus and HPV positive, you want to get them right to colposcopy. Save that extra step, extra providers of being seen by. So optimal treatment is not clearly identified for all classes of CIN in the HIV-infected population. It's not in the immunocompetent population either, but we have much better data for those women. These women should automatically consult with, if they have abnormal Pap smear results that I just talked about, with an HIV-experienced gynecologist, and I emphasize that, HIV-experienced gynecologist, GYN oncologist, or dysplasia specialist. I've seen many times in my career where patients are referred to a gynecologist. They do the colposcopy, they get abnormal results, and what do they do next? They refer them out to GYN oncology. And so that's another step for the patient to get lost in. And she's out of your system, she's in another system, and you want to keep control on her. So if you can do it in-house where it's GYN oncology or dysplasia specialist, much better. Treatment of high-grade lesions, we have many ways to treat them. We can ablate them, we can use cryotherapy, we can excise them, take them out. 2 ways is by cautery, or the other one is known as a CKC, cold knife conization. We don't do that very often. You might have heard of it because it's association with preterm labor and delivery in young women, and we don't want to have that happen. So only if severe high-grade disease is suspected will they do that. Wow, I'm burning rubber here. Okay, so conclusions for the medical follow-up. So we can take some questions and answers after this one, because I go and then Meg will go. Abnormal cervical cytology is definitely more common among HIV-infected women. Have you seen that in your practice? Yes, okay. Women infected with HIV should be screened for cervical cancer annually till they have those 5 years of annual, and then they can go to 3-year screenings, okay? They never exit out of screening. The incidence of cervical cancer among HIV non-infected women and HIV-infected women who are immunocompetent and screened annually are the same. So if we can get those patients in the system as soon as they're diagnosed, get them on their antiretroviral therapy, and get them immunocompetent, their risk of cervical cancer plunges. Okay?
Okay, so in terms of trauma follow-up is, you know, if someone tells you that they've been abused, whether you're asking them or not, validate that it was, you're glad that they told you and that it was a good thing for them to tell. Again, don't try to fix it, offer support, and ask them whether they're having any current problems. If someone says, I'm being abused right now, then you need to do something about that right there. And check their emotional state at the end of any exam or interview. And just how are you feeling, or are you feeling okay? And offer follow-up. So it's important if you're going to ask about trauma, in case someone needs follow-up, to know where they could be referred to. And then you don't have to fix the problem, right? Nor can you. So it's important to know a clinic that you could send them to. Okay. The other thing I just want to mention is that we're telling you to always ask about trauma, and I don't know if trauma is in the forms that that you're using, or I mean I think if it has to be all around that everyone's asking for trauma, so just not one of you can start asking about trauma, no one else is. So I think it's important to sort of have support of your supervisors that everyone's going to be doing this, and maybe have that discussion about it.
Yes, so like I said, cervical cancer can plummet if they're treated appropriately, but being sexually trauma informed helps keep your patients in the loop of the system. And we don't want to lose patients out of the system, and so one more step that we can take to keep them in here is going to be beneficial to them and to society.
Right. I mean, that's really why we've added the trauma into this talk, because we're seeing that a lot of patients are just really not coming, and we think a lot of it has to do with this missing piece of trauma and not discussing it.
Any questions? Yes?
I'm actually curious to know whether or not you guys ever experienced people saying that childbirth is kind of a trauma, like their experiences with childbirth, whether it's, that it can vary, obviously, but like there's some women who experience, like, for instance, and this may be rare, but pelvic separation, and then having to go back in for violence and not necessarily.
It's not common. The question was, have we seen anybody with childbirth trauma? And the answer is yes. You can have very difficult delivery, close to loss of life, injuries during delivery, and yes, these all can make pelvic exams very difficult for you. So that's why she used the blanket word trauma when she first started out, and then funneling down to where the information goes to what kind of trauma it is so that we know.
Yeah, that's important.
Good question.
Any advice for older women that they're just, no more estrogen, and they really don't like it anymore either? And it may not be trauma related, it just may be for them.
Atrophy.
So, yeah.
So those patients, I have them use some vaginal estrogen a month before the exam, whether it be just, what's the oldie but goodie?
KY.
No. Premarin before, okay? And believe it or not, if you can get a pediatric speculum,
Okay.
works better. And you just lubricate it well. When you apply lubricant to your speculum, do not apply it to the distal edges. You can lubricate a speculum, okay? A lot of people think you can only use just water, but on plastic speculum, water just rolls right off. So you just want to make sure you don't get it on the distal edges of the speculum. And just lubricate it really well. So if you can get your department to order a bag of pediatric speculums, where I work, we have metal speculums, so I have a metal pediatric speculum, I have a metal small speculum, and for those patients who are a little fluffy and it's harder to visualize things, it helps me with that exam. Although using a metal instrument may not be easy to use for somebody who's had trauma, so you have to be careful who you pick and choose to use that with. But yeah, some estrogen therapy before, definitely.
I mean, the other thing is I would not make any assumptions about people's sexuality and ask them about if they have any concerns, because I treat people that are in their 90s that are sexually active, and people in nursing homes fall in love and start having sex when they haven't and don't know what to do about atrophy. So it's important to ask.
And I'm sorry, I just wanted some clarification on the annual. I think you guys said In terms of like how often a person should have an exam, whether it's annually, which is what I think most people are familiar with, as opposed to every 3 years. And
Well, the guidelines didn't say that they actually needed an annual exam, gynecological exam. They needed an annual exam from here down, but that's the standard of care for immunocompetent, non-immunocompetent, is they get an annual exam, they get, heart, lungs, breasts, pelvis, and the pap smear exam. So, and that's done usually on an annual basis. They may not always need, in the immunocompetent population, a pap smear every year, but they still need to be looked at down there. Many women are taking an a mirror and looking down there like this and saying, oh, by the way. So that's our job to do that and look down there for them. And I've caught lesions that way. I said, you haven't been here in 2 years, and all of a sudden you have a lesion, and we need to do something about this. So, yeah.
Any other questions? We used to have a colposcopist who worked at our clinic. She retired, and now we refer to GYN for colpo. But even when we had her, it was a struggle getting patients in for their colpos. What strategies have you tried at your institutions to encourage patients to go forward with the colposcopy?
That's a tough question because it is hard to get a patient recalled for a colposcopy, especially once the procedure is explained to them and they go online and they look and see what the procedure entails. And it's a lot of phone calls. It is. It's just a lot of phone calls. We don't have the magic bullet here either. So.
But maybe talking to them about their feelings about it, or what they're anticipating, what they're anxious about. So their psychological state as well as their physical concerns about it might help.
I guess that raises a question for me. Are you familiar with anybody that's ever tried to like have a support group, or like a psychoeducational like 2 to 3 sessions with other women about?
That would be great.
Yeah, I don't know if it's been tried and worked or not worked, but you know what I'm saying?
Yeah, I mean, I don't know the research on it, but we could certainly look it up. But it sounds like it would be really good. I mean, because we keep saying support is really important.
Yeah, that's something
Yeah.
you could bring in a bunch of women and say this is, have an educational thing for them before.
Answer questions,
um,
talk about it. That's a great idea. You could try that and see how it works.
Thank you.
Well, I want to thank you all for coming. This
Thank
is very
you.
informative.
Thank you.
Thank you so much.
Thank you.